Okay, I think we'll go ahead and get started. So welcome to the last oral abstract presentation of the symposium. My name is Nadia Ran. I'm a professor of urology at UCSF and a senior investigator at the Gladstone Institutes, and I'll be one of the two moderators of this session. So jumping right into it, our first speaker will be Lauren Collins, who is an assistant professor of medicine in the Division of Infectious Diseases at Emory. And the title of her talk will be Association of Pregnancy History and Age with the Burden of Non-AIDS Comorbidities Among Women with and Without HIV in the Southern U.S. Dr. Collins.
Good morning. I'd like to begin by thanking the conference organizers for giving me this opportunity today, and also for putting together a fabulous morning session, which really sets up for this oral abstract session so nicely. So as mentioned, I'm Lauren Collins, and I'm from Emory in Atlanta. And I will be presenting this work on behalf of this incredible co-author team, including my amazing mentor, Dr. Nandi Sheth, and our team from Atlanta, as well as the list of star collaborators that you are all very familiar with at this point in the meeting. And I want to give a special shout out to Ava Cox, who is a master's epi student at Emory, who helped tremendously with this analysis over her summer practicum. I don't have any disclosures. So in terms of a brief outline, we'll give a background that at this point I think is pretty well established, review the study aims, and then go through methods and some preliminary results from our STAR data, and then wrap up with conclusions and future directions. So as has been discussed, we all know here that persons with HIV are living longer, but importantly, this extended life expectancy is not comorbidity-free. Those individuals that are living longer is mostly attributable to tremendous advancements in antiretroviral therapy, or ART, and as has been mentioned in the US, for those with access to treatment and care, more than half of persons with HIV are aged 50 years or greater. And increasingly, persons with HIV are therefore at risk for aging-related conditions like heart and kidney disease. This was a really nicely done study by Kaiser Permanente, which shows the overall life expectancy among people with and without HIV, shown in triangles for those with HIV and circles for those without. And we can see over the past few decades, there's been a narrowing in life expectancy by HIV serostatus. However, this is not true of comorbidity-free life expectancy, whereby differences in HIV serostatus have persisted. And it's estimated that persons with HIV live 16 fewer healthy years than those without. So given that background, I've primarily been interested in how sex and gender affect comorbidity prevalence and burden in people with HIV, given the complex interplay between these not-so-bucketed buckets that we commonly refer to, as was nicely outlined previously. And in particular, how early in life do differences in comorbidity risk emerge by HIV serostatus? And my work, for reasons we're all familiar with here, has primarily been focused on cisgender women. So this was a study that we did recently looking at aging-related comorbidity burden among women and men with or without HIV in the US, and we leveraged data from the MaxWise combined cohort study. Shown here, you can see different strata of comorbidity status, and I'll go through which comorbidities were assessed in the next slide. And these graphs are plotted by HIV serostatus as well as gender. And among nearly 6,000 participants, looking at a primary outcome of 10 total comorbidities assessed, we found that women had a statistically significant higher comorbidity burden than men. And importantly, this was concentrated, or the difference was most significant in those with HIV, and the distribution of non-AIDS comorbidity prevalence differed by sex. For example, lung disease and diabetes were more common among the women than the men. Shown here is estimated comorbidity burden, plotted by HIV serostatus and by gender. And what you can see on the left is among persons with HIV, women compared with men had a higher comorbidity burden in every single age strata examined. However, this trend was not true among persons without HIV. And interestingly, when we adjusted for covariates, which are shown here, including race, ethnicity, BMI, socioeconomic status, and then use of substances, this difference was slightly attenuated, although still significant, which is to say, again, that there may be a lot of undertone in sex and gender that's related to social determinants of health, which are harder to capture. Briefly, this is a study that we did using data from the WISE, where we looked at comorbidity incidence to address the second question of how early in life does comorbidity risk emerge by HIV serostatus. And so shown here is a plot of women with and without HIV, and you can see the 10 comorbidities that we assessed, including hypertension, psychiatric illness, bone disease, dyslipidemia, liver, lung disease, diabetes, and cardiovascular, kidney disease, and then cancer. This study included over 3,000 women and nearly 37 women years of follow-up. We determined comorbidity status at baseline, and those with any prevalent comorbidities were excluded. At baseline, median age was 37 years. And then we followed over time to assess incident comorbidity burden, which is shown here on the right, stratified by age group. And strikingly, what we found is that the difference in incident comorbidity burden by HIV serostatus among women was greatest among the youngest age group women. So those that were less than 25 years of age had the greatest difference in incident comorbidities when comparing those with and without HIV. So the overall goal of this research program is to refine multimorbidity screening and prevention. As we've shown now, we're not just talking about one or two comorbidities, but multiple that sort of coalesce over time and can have compounding impact. And so we'd like to refine screening and prevention in persons with HIV, especially given that compared with the general population, risk is greater and occurs earlier in life, as well as considering that routine screening tools like the 10-year ASCVD risk score, for example, are less sensitive in persons with HIV, again, compared with the general population, and that this is most significant among women. And again, we know that the impact of multimorbidity in this population is enormous, including premature mortality, affected quality of life, and excessive healthcare expenditures. So the aim of this study was to evaluate the impact of HIV age and pregnancy history on comorbidity burden among younger women, given our finding from that incident analysis that those in the third decade of life seem to be at greatest risk. And this is sort of in the broader context of being interested in how women's health transitions affect comorbidity risk across the lifespan, including both pregnancy history as well as menopause. So we leveraged the Study of Treatment and Reproductive Outcomes, or STAR, which is enrolling women 18 to 45 years old across these 6 EHE, or ending the HIV epidemic jurisdictions in the US South. And in terms of methodology, this was a cross-sectional study of STAR participants at their enrollment time, and those visits occurred from March 2021 through January 2023, and characteristics, covariates, and outcomes were determined at the time of enrollment. Independent variables included HIV age and pregnancy history, and we defined the latter as having had 0, 1 to 2, or 3 or more prior pregnancies, and any current pregnancy would have been excluded from those counts. And then outcomes were comorbidity prevalence and burden, which we defined the latter as the total comorbidity count of 12 assessed, so the 10 previously mentioned, as well as obesity and anemia. And linear regression models evaluated the association of comorbidity burden with HIV serostatus, age, and pregnancy history. So briefly, the characteristics of participants included in this study, which were a total of 519 women, 68% living with HIV and with a median age of 36 years. 75% reported non-Hispanic Black race, and 45% ever smoked. In terms of prior pregnancies, you can see the distribution here, with 32% having 1 or 2 priors, and 22% having none, and 46% having 3 or more. In terms of the women with HIV, median CD4 at enrollment was 666. Nearly 80% had HIV suppression, and 74% reported use of a INSTI. So findings are shown here of non-AIDS comorbidity prevalence by HIV serostatus, and you can see that the range is pretty broad, depending on the comorbidity evaluated, in terms of obesity being upwards of 60%, down to cancer in this younger age group, as you would imagine, as low as 1%. In terms of differences by HIV serostatus, those that were significant were psychiatric illness and liver disease, both being significantly higher in women with versus without HIV, though noted as the smaller sample size, and there were a couple of additional trends, including anemia and kidney disease, that were also nearly significant. In terms of looking at comorbidity burden, which was the primary outcome, there were 332 women that had available data for all of the 12 comorbidities assessed. And in comparing women with and without HIV, we did not see a statistically significant difference by the number of comorbidities. However, of note, those with and without HIV had 2.5 or 2.4 comorbidities. So even in this younger age group, multimorbidity was incredibly common. And not surprisingly, there was a significant trend by age group in terms of the overall comorbidity burden increasing with age. In looking at the distribution of comorbidities by pregnancy status, among women with 0, 1 to 2, or 3 or more prior pregnancies, the age-adjusted mean comorbidity burden was 2.4, 2.2, and 2.6 respectively, and in terms of a trend, this was not significant. So to summarize, HIV serostatus did not modify the effect of age and pregnancy history on overall comorbidity burden. So the three-way interaction term was not significant in this smaller and preliminary look at the STAR data. However, interestingly, these are model-based estimates stratified by age group that look at the estimated comorbidity burden by pregnancy status. And we did find that among women across HIV serostatus, pregnancy history was associated with estimated comorbidity burden in certain age groups, and most significantly the women aged 25 to 29 years old, with some trends in the 30 to 34 and 35 to 36 age groups as well. So in conclusion, among reproductive age women with and without HIV in the U.S. South, the burden of 12 non-AIDS comorbidities was high overall, increased with age, and was associated with pregnancy history in some age groups. And these data may inform the development and timing of novel comorbidity screening and prevention strategies to be deployed across the reproductive life course, especially considering that a period in a woman's life whereby they are most engaged in healthcare sometimes is when they're pregnant. So in terms of future directions, we'd like to expand this pilot analysis to include more participants, and those data will be presented at CROI this year. We'd like to evaluate comorbidity incidence, including the development of comorbidity clusters in terms of dyads and triads over time and shared risk factors. And we'd like to specifically assess the contribution of pregnancy history elements in terms of comorbidity markers across the pregnancy transition periods, including metabolic disorders and blood pressure and weight changes, as well as assess the contribution of menopausal transition, which Dr. Abelman had alluded to, our preliminary data published from the WISE as a cross-sectional analysis, but more to come there in terms of looking at those data longitudinally. and then to design and test HIV-specific and sex-tailored multimorbidity risk assessment and mitigation strategies in women, considering biomarkers, which the earlier session set up really nicely for, to give some ideas into including different inflammatory signals, and then the basis of my K23, which is to look at microvascular precursors by using retinal imaging as a potential early marker of multimorbidity. And then also, of course, better incorporation of social determinants of health assessment and intervention. With that, I'd like to acknowledge the STAR participants and our community partners, as well as the STAR leadership, staff, data analysis and coordinating center and collaborators, as well as my career development funding, which is a K23 through NIA with support from the Office of AIDS Research and Research in Women's Health, and the Emory Persevere Award. And on the left pictured here is our Atlanta STAR group, and on the right is our team Rhythm, which is research in HIV and women's health and why this harmony matters. And I encourage you to check us out, and our website is listed there. Thank you very much.
Thanks, Lauren. That was a nice talk. I'm pleased to introduce our next speaker, Jacqueline Odiambo, who is a PhD student at the School of Public Health and Community Development at Maseno University. And she is going to talk about the title of her presentation is Widowed and at Risk, Increasing HIV Prevalence Among Kenyan Widows in the Last Decade. Thanks.
Thank you very much, and it's a delight to be here and to share some of the work we are doing in Kenya. So I guess to start off, I just want to set the stage with understanding of the burden of HIV among women in Kenya. So similar to what we have heard before, Kenyan women bear greater burden for HIV, 66% of the 1.3 million people living with HIV. And so that is sort of twice the burden experienced by men. And then the sex disparities we are seeing between males and females in Kenya are heightened in one particular region in the country called the western part of the country in the Lake Victoria region. So this region particularly has had a history of higher HIV prevalence in the country that is usually 3 to 4 times the national average. So Siaya County, where the study I'm presenting occurred, has a HIV prevalence of 15% compared to our national average of about 5%. Then the second point I want to make is that the current literature does show that marital status is an important risk indicator for HIV infection, and there's literature showing that widowed women have higher odds of HIV infection compared to other marital status. But before I delve a lot into that, I just wanted to share a bit more about widowed women, because I don't think it's a population that we talk a lot about. There is some statistics it's kind of a not so recent now, published in 2015 on Global Widowhood Report that showed there's about now 300 million widows globally, maybe 24 to 30 million of them in Africa. And among these, in this report, they were saying 1 in 10 adult women is widowed, and 41% of widowed women, especially in Africa, experience extreme poverty. In Kenya, we also don't have good statistics about widowed marital status, and particularly widowed women, but there's an estimate of around 4 million widowed women in Kenya. And in a recent study we just did in the Lake Victoria region, 97% of these women identify as household heads. So based on the data that already exists from the literature, studies that are looking at marital status as a potential risk factor for HIV infection show that widowed women have 2 to 6 times higher odds of HIV infection. That is when you compare with the single never married women or even with married women. And sometimes the results is mixed when you compare it with the divorced and separated women. And then there is a number of qualitative studies also across the region that try to highlight potential risk pathways for widowed women, and these based on cultural, social, and also economic context. So for example, for cultural reasons, there are practices such as widow inheritance, in which widowed women get remarried within the clan or the family where their deceased husbands came from, or practices such as sexual cleansing, in which widowed women are perceived to be a bad omen, after death, unless they are cleansed. So those kind of practices, some literature have shown that they increase the risk of HIV spread. And then there's also other factors such as transactional sex, which comes about as a result of the economic vulnerability that women experience when they become widowed and they have to be the breadwinner, the sole breadwinner in their families, and so on. So there is a lot of factors that have already been highlighted in qualitative work. In our study, we wanted to look at this question from now quantitative perspective, and looking at both the prevalence of HIV among widowed women and also the risk factors, and we decided to compare these between widowed women and married women. So our study is anchored on a health and demographic surveillance system that is led by our National Research Institute in the country called KEMRI, in partnership with CDC, and they've been doing this demographic surveillance in a region called Siaya for the past 20 years. And 10 years ago, they incorporated HIV home-based testing and counseling in the program. And so we did our study as a cross-sectional analysis of the HIV home-based testing and counseling data that has been done 5 times between 2011 and 2022. So we included only married and ever widowed women in the analysis. And HIV status, usually it's either blood tests during these home visits that happen every 2 years, or sometimes it's a self-reported test based on medical records. Then because this is an open cohort in which every 2 years the KEMRI goes and collects data in this population, in terms of how we selected covariates to assess for the risk factors, if a woman appeared in the cohort only once, then we took their covariate at that time point. But if they appeared in the cohort more than once and became HIV infected at some point, we analyzed covariates or risk factors for HIV positivity around the time when the positive test was confirmed. And if they were negative throughout the multiple occurrences in the cohort, then we took their most recent appearance in the cohort, the risk factors, the covariates in that period. So we did our analysis stratified by ever widowed versus married, just comparing those two groups, and looked at HIV prevalence, also over time, between 2011 and 2022, and then we did logistic regression to assess for the risk factors. So we have a total of 14,445 women in the analysis, and 27% of these women are widowed, ever widowed. And so comparing this to that earlier statistic of 1 in 10 adult women being widowed, it seems like in this particular region, the rate or the proportion of women who are widowed is a bit higher, probably 1 in 5, 1 in 4, because the proportion of adult women who identify as divorced or separated is much smaller. And then when you look at some of the demographic factors, you can see here that 57% of the widowed women, were 60 years and above, so that is the orange bar, and 8.3% of married women were aged 60 years and above, and then majority again of the widowed women had no formal education, 34% compared to 5.9% of the married women. So when it comes to the question about HIV prevalence, you can see here for the yellow bar, 1 in 4 widowed women in this cohort is HIV infected. Compare that to the 17.1% among married women. And actually, this statistic is corroborated by a national report that came out last year in 2022. The Kenya population-based HIV impact assessment that also looked at this question of marital status and HIV prevalence. And you can see the females are the light blue, and then the males, the green bars. And you can see for the widowed women is that the largest light blue bar. So kind of similar proportion of percent of widowed women having a higher proportion of HIV prevalence. When we looked at the trends over time for HIV prevalence, comparing these two groups of women, again, the yellow line is for the widowed women and the blue line is for the married women. So you can definitely see across 2011 to 2022, widowed women have had a much higher prevalence of HIV, and the trend has actually been increasing over time. As compared to the married women, which still it's a higher prevalence, starting at 15% in 2011, increased a bit up to 2018, and then between 2018 and 2022 was declining a bit. So we also asked ourselves, what is the role of age in these in the prevalence of HIV, comparing these two groups of women? The dotted lines are for married women, and then the bold lines are for the widowed women. And you can see, again, here the red are the older women, 60 years and above. The blue are the middle age, 45 years to 59 years, and then the black are the young women, less than 45 years. So you can see widowed women, both those who are less than 45 years and those who are between 45 to 59 years, having also, again, the highest HIV prevalence over time. And you can see for that middle group of 45 to 59 years, the trend has been increasing a bit. And this, again, also compares just well with the reports from the population-based HIV impact assessment, which showed 36% of widows of reproductive age having widows of reproductive age, 36% of them being HIV positive. So showing that there's a high burden again in that group, not just in this region, but also from this report that is reporting. These national reports showing the prevalences across the country. What's critical about this number is that when you compare this statistic to the national average HIV prevalence for priority populations, for example, men who have sex with men, or persons who inject drugs, or female sex workers, you find that this group of women, widowed women of reproductive age, having actually a prevalence that either compares or is just higher than those groups that are considered currently priority populations in the country. So on the question of risk factors, our results again are similar to what is in the literature in terms of widowed women having higher odds of HIV infection than married women, and this is like 6 times higher. And these are the covariates that we controlled for in the analysis. But then when we also looked at these covariates as risk factors, we've already seen the aspect of age being for younger women, and this is actually both for married and widowed women. You see that the younger ones have a higher odds of HIV infection. What was particularly surprising or new to us in this analysis was looking at the issue of age of the sexual partners for the women. So there's already studies showing age-disparate relationship between younger women and older men, that there is high HIV infection in those relationships. Here we were seeing the reverse of older women who are having younger sexual partners, being more likely in these analyses to be HIV, having higher odds of HIV infection. Also, those who experienced forced sex had a higher HIV infection, odds of HIV infection, compared to those who never experienced forced sex. Tertiary education was protective for the married women compared to those who had no formal education, and then informal employment was more of a risk factor for married women compared to those who are unemployed. So in conclusion, what we are seeing from this analysis is that widowed women have both high and an increasing rate of HIV prevalence over time in this particular region, and that these elevated risks is among younger widows, and also those who are having younger sexual partners or experiencing forced sex. And in terms of what we feel should be done, there's need for more research and policy to prioritize widowed women in the HIV control strategies, particularly given that we are finding the prevalence in this group not so different from those other populations that are currently considered priority populations in the country. And if this happens, especially with research, there's still a lot more to learn, even understanding these age-disparate relationships, how they are occurring, where they're occurring, and what kind of targeted interventions would be needed to address the unique challenges that widows face in terms of HIV prevalence. Our analysis only looked at a few risk or factors that were included already in this database that we used, but there's so many other factors that have already been reported in qualitative work that were not measured here that would need to be looked at, especially the cultural practices like widow inheritance, sexual cleansing, and other potential risk factors. So with that, I just want to thank the study participants and also my co-authors, and I think some of them are in here, and SIFA for the opportunity to present this work. And also, my doctoral program is in Sustainable Development for HIV Health Program, which is a D43 training program, and some of my mentors are here. Thank you, and thank you all for listening.
Thank you, Jacqueline, for that really excellent talk. Our last oral presentation for this session will be given by Kerrigan Parrish, who is an assistant professor at Columbia University. The title of her talk will be Oral Health-Related Quality of Life and Unmet Dental Needs Among Reproductive Age Women with HIV.
Thank you. Hi, everybody. I'm here to talk about everyone's favorite topic, teeth, right? We all have dental stories, dental problems. As she mentioned, I am affiliated with Columbia University, but at their Miami Research Center. So having said that, I work with the University of Miami STAR /CCS site. I'm very happy to be here. I went to college across the Bay almost 2 decades ago, so I feel like I'm home. So thank you for having me. So here today, I'm going to be talking to you about the oral health component of STAR. I think I'm the last speaker, so I'm sure you've all heard about STAR, but it's young women of reproductive age living with HIV or at high risk for HIV. So just as some background, persons living with HIV are more likely to experience oral health problems, including opportunistic infections and periodontal disease, compared to those without. HIV-related oral lesions, I have a little table on the side there, are present in approximately 1/3 to 1/2 of people with HIV and can either serve as early signs of HIV infection or can be associated with low CD4 count or poor immune function. Also, those who chronically take antiretroviral therapy to control their HIV infection are more likely to experience diminished salivary flow, which can affect chewing, swallowing, your ability to talk. It also increases your dental caries risk or your cavity risk because saliva is actually protectant against cavities. Dental disease and infections can also be more severe and difficult to treat in people with HIV than those of the general population. I have a few pictures there from way in the early days of the HIV/AIDS epidemic showing some of those oral markers. Prior studies have highlighted the unmet dental needs of people living with HIV, especially in comparison to other healthcare treatment needs. Study data have shown that unmet dental needs are twice as common among people with HIV compared to unmet medical needs, especially among those without dental insurance. In the past few years, dental care utilization among adults in the US has been in decline due to insufficient dental coverage. So despite this current era of national healthcare reform, the income and dental insurance inequality gap has not improved, and in many states has actually worsened as Medicaid dental benefits are increasingly becoming more limited, and poor individuals are experiencing worsening barriers to routine preventive dental care. As a result, individuals without dental insurance constitute a population at high risk for having persistent unmet dental needs and relying on hospital-based emergency settings to treat urgent dental problems, which is especially problematic because it turns to problem-focused care as opposed to prevention. Also, very, very few hospitals and emergency departments have dentists on site. However, securing dental services has shown not just to be a money affordability issue, especially among women living with HIV. So women with HIV of reproductive age encounter many barriers leading to oral health disparities, including caregiving responsibilities, especially when you have young kids and aging parents, eclipsing medical needs that take priority over dental care. Stigma, huge barrier towards receiving preventive dental care, and as I mentioned, financial barriers that impede this routine preventive dental care. So neglected dental care and oral symptomatology, such as pain, plays a significant role in overall quality of life and general health by negatively affecting form, function, and your ability to socialize. Oral health-related quality of life has therefore become a really important construct in evaluating how untreated dental disease can affect your overall quality of life and well-being. So here on the bottom left, you see this overall umbrella of quality of life, your spirituality, isolation, socialization. Within that, we have health-related quality of life, and then within that, we have oral health-related quality of life. So for any of you who have ever experienced dental pain, it can be very debilitating. They always say the three worst pains: childbirth, kidney stones, and dental pain. I've also, heard stories of mother of the bride who chips her front tooth, hours before the photographer takes their photos. I've seen it all. I've heard it all. But so from this, we have this concept of oral health-related quality of life. The first ever Surgeon General's report on oral health back in 2000 acknowledged the significant role that oral health plays in overall health-related quality of life. It was noted in this report that oral health has the potential to undermine self-image, your self-esteem. It discourages normal social interaction and can lead to chronic stress and depression, given its association with so many things: your diet, your nutrition, your ability to sleep, your psychology, again, social interaction, and school and work, given the number of missing days at work or school, especially amongst young children due to early childhood caries. So in his 1998 model of oral health-related quality of life, Locker applied the World Health Organization's definition of health to demonstrate this progression of dental disease into symptoms that then inhibit physical and social functioning and promote negative perceptions of oral health, diminished overall health, and general quality of life. So investigators have developed questionnaires to evaluate this construct and the changes in oral health status and overall health-related quality of life over time. So one of the most validated measures is SLADE's generic 49-item OHIP score, which stands for the Oral Health Impact Profile, which includes 7 conceptual subscales formulated based on the prior theoretical model of oral health. So you see these constructs on the left, and they're identified for their appropriateness in assessing the important impairment and functional status dimensions related to general oral health conditions. So, for example, functional limitation might be when you have an oral health impairment, your ability to chew, your ability to talk, your ability to swallow. When it comes to, say, for example, psychological discomfort, I always like to give this story. I was a 4th-year dental student at Harvard, and my Nana, my beloved Nana, was having open heart surgery at the Brigham. So I was sitting with her in the pre-op area. The anesthesiologist comes in, and he says, "Gloria, it's time to take out your teeth." She pops out her upper and lower denture. I never knew my Nana had dentures. And here I am, a 25-year-old fourth-year dental student, and I said, Nana, mind blown, why didn't you ever say anything? She said, because Kerrigan, it's embarrassing. I said, but Nana, I'm your granddaughter. I'm going to be a dentist in a few weeks. I can do adjustments. I can replace it. You should have your dentures replaced every 10 years. And she said, Kerrigan, it's embarrassing. So just things to think about. It's not just about pain. It's about smiling. It's about talking, socializing, feeling self-conscious about the way you look when you smile. Anyway, because these longer, time-consuming 49-item scales can be a bit cumbersome and burdensome for staff as well as patients, especially with these long visits that occur in some of these cohort studies, shorter versions have been implemented, including the 14-item version of the OHIP and the 5-item OHIP. Which right here is what we have implemented in the STAR study. The CCS study uses the 14-item OHIP scale. But with the OHIP 5, we ask these 5 different questions. Participants respond on a Likert scale ranging from never, hardly ever, occasionally, fairly often, or very often. And the way it's coded is that higher scores reflect worse oral health-related quality of life. Oh dear, I don't know what happened there. My apologies there. I don't know why that turned out this way. But within the STAR, so again, this younger cohort of women, these analyses for today were just on the initial subset of 518 women, 354 of which are women with HIV, 164 without HIV. We're doing a lot of great work within STAR and CCS and another study I'll get to at the very end. But for STAR, we're collecting some of these oral health measures. We're also taking dental photos so we can look at any gross pathology. Again, this does not replace an in-person dental visit, but any obvious lesions, especially when our staff and our nurses who are not, who don't have an oral health background say, this might not look right, let me take a picture. We can also look at tooth loss over time, which is a major indicator of periodontal disease. We're also doing saliva samples, and swabs, and with a subset of pregnant women within STAR, we're also doing more thorough exams, but that's beyond the scope of today's talk. So here are some descriptive statistics of again, these 518 women. None of these findings were statistically significant, but they're very important to talk about. So the median age of these 514 women was 35. Again, the range for STAR participants is 18 to 45. So we ask in the past year, have you received dental care? Now, ideally, we want to see the dentist for preventive care at least twice a year. American Dental Association says, okay, if you can't do twice a year, the minimum is at least once a year. So we ask these young women, again, who should be receiving regular preventive care, because I don't want to see in a 35-year-old, I don't want to see evidence of generalized recession. I don't want to see these major periodontal markers. When we asked them, less than half of women overall had received dental care in the past year. Slightly less for women without HIV, but again, not statistically different. We also ask, in the past year, have you had a dental problem that was left untreated? Again, approximately 1/3 of these young women reported having a dental problem but did not seek treatment. So then we take it one step further and we ask them, well, why? With the most common reason being they were either uninsured or unable to afford dental care. The second most common reason was they didn't think it was important. Again, with this population, we see I have so many other medical issues that take precedence over my routine preventive dental health. And also a lot of times the problem went away. So when we have tooth pain, when the nerves end up dying, a lot of times that pain goes away. It still needs to be treated, but hey, it doesn't hurt anymore. I'm going to move on with my day. We also ask, how would you rate your oral health condition? So when it comes to self-reported oral health status. More women without HIV self-reported their overall health status as being excellent or good, with about overall less than half, 46%, saying that they would rate it as excellent or good. Again, these are really, really young women. We should be seeing this much higher. In looking at the OHIP-5 score, again, as a reminder, higher scores indicate worse oral health. The mean OHIP score for women with HIV trended higher, again, reflecting worse oral health-related quality of life than that of women without HIV. So study findings are showing suboptimal use of dental care and high unmet needs in reproductive age women with HIV, specifically in the setting of financial barriers and potentially worse oral health-related quality of life compared to women without HIV. In these HIV research settings that we're all a part of, it is absolutely critical to do dental assessments and oral health-related quality of life assessments in order to identify significant dental treatments in the context of HIV infection. And assessing these factors that affect oral health in these populations provides critical information on unmet dental needs and identified gaps to enhance care delivery. Furthermore, this relationship between dental health, oral health-related quality of life, and other indices of HIV and general health have really important clinical implications and are key to understanding oral health among women with HIV. Just on a quick note, we've also received at the UM and UNC sites an NIDCR-funded study called The Crown, where we're looking at the interplay of HIV, oral health, and mental health in women aging with HIV across the reproductive lifespan. At the UM site, we started seeing patients on Halloween. We have 21 women enrolled so far. And while this data we collect in STAR and CCS is wonderful, I'm actually doing in-depth dental exams on these women, and the stories I hear are absolutely heartbreaking. So when we talk about, well, you should just go see your dentist twice a year, what's the problem? Well, we're seeing women with multiple children who have their own dental problems, their own dental needs, medical needs. I had one woman, I was examining her TMJ. We looked for, pain, clicking. I said, does that hurt? And she said, well, it's not that bad ever since I was, stabbed in the jaw by my boyfriend and had surgery and my mouth was wired shut for 6 months. It's gotten a little bit better. I've had dental exams interrupted by phone calls from Department of Children and Families, and they're trying to get their kids sorted out and arrangements made. And again, dental health takes a back seat. But if we don't get involved at an early age, that's when we're gonna see the problems only get worse. So I thank you for your time, your excitement over dental and oral health. It's been quite a journey getting these studies and instruments included, again, because there's so many other eclipsing medical needs. So thank you.
Okay, the floor is open for questions. Thank you, Kerrigan. That was a really interesting presentation, too. Okay, I will start with the first question, and this is for Lauren. I thought your presentation was really interesting, and I was wondering if STAR is collecting more detailed data on pregnancy outcomes, like age of first pregnancy, preterm birth, live birth, because those could also be, markers of social determinants of health.
Yes, that's a great question. Thank you. STAR is collecting all of those data points in detail, and we look forward to doing a deeper dive into pregnancy history specifically, and then also in correlation with metabolic changes across pregnancy too. Yeah, that's a great point. So thank you.
Craig.
My question's for Jackie. First of all, congratulations. It's great to see this presentation come to light. My primary question, obviously an increase in prevalence by itself is not necessarily a bad thing, right? Because it's a marker, it could be a marker of increased incidence and or survival, especially with HIV care and treatment being widespread in, say, a county. My question is, did you collect data on what proportion of the individuals that were enrolled in this study are receiving HIV care and treatment, including ART, maybe even viral suppression? And then do you have any insights? I know incidence obviously is more difficult to measure, but do you have any insights directly on incidence over time? Because obviously in Kenya, we've seen overall general population a significant decline in incidence due to many different factors.
Thank you, Craig. So in terms of care and treatment, the data sets we are using have that information, but for this particular study, we just wanted to look at prevalence and compare that and changes in that over time. So that data is there, we just didn't analyze it for this particular project. Then, yes, the next study we want to do is to look at incidence in the same cohort over time, because now there's data between 2011 to 2022 to then do the similar study, but now comparing on incidence. Has that changed in what directions for widowed and married women over time? But the other thing about the prevalence, of course, for widowed women, oftentimes we say, well, in this region, the prevalence is high, so probably they are widowed, they got infected in marriage, and then they are widowed as a result of HIV. But we do want to, again, do more analysis to understand that better, because we see a lot of qualitative research showing increased risk behaviors during widowhood, but we haven't seen studies looking at how does that translate into either more infection or not. So those are the questions we are trying to explore further. Thank you.
Elizabeth.
Hi, Jacqueline. I may no longer have to ask my question based on your answer to the previous question, but I'll just share my thought with you. That's what I was thinking was the potential for confounding by HIV status of the deceased husbands. You talked a lot about interventions to target the risk behaviors sort of starting from the point of widowhood, really, right? Looking at these widowed women, and I appreciate that you're studying this population because we don't hear a lot about widowed women specifically. Excuse me. But I wondered whether there were prevalent cases, right, where they, just as you said, they were widowed because their husbands were infected with HIV, and therefore the interventions targeting women who were widowed would come too late in the process for them. Yeah. Thank you.
No, yeah, thank you for that. And there's a study that we will be collecting data on around April next year, in which we have a question in it, trying to just get to a sense of when did you confirm your HIV positivity? Is it while in marriage or 2 years after your husband died? Again, it's not the most accurate in terms of determining, but to give us a sense. Usually, a majority of the women get to know their HIV status after the death of their husband, but now then it's figuring out, did that occur during their marriage or after marriage? And then the other thing I wanted to add is when it comes to the cultural practices, there's a lot that has changed. I mentioned the practice of widow inheritance. Traditionally, a widowed woman gets remarried within the clan or the family, and that in those earlier years actually increased the spread of HIV within the family, because if one person was infected and you remarry within, but then right now the practices have changed so much in a way that actually it increases the potential, the risk for HIV infection for the women, in the sense that now you have men, not necessarily from the family, being the ones inheriting the widows, but then you'd have one man having relationship with 7 different women, and so if that one man was infected and then he's going to inherit 7 different widows, he might be increasing the infection. So those are the patterns that we kind of want to continue studying now to understand what's going on, and then that may inform what kind of interventions do we need, particularly for women when they are widowed. So for example, even the age-disparate relationships that we are seeing in the results that we had, there's some qualitative work that is already showing that widowed women are now having more relationship with younger men, and then these younger men have other partners of their ages and all of that. So there's a lot that we still need to unpack and understand in terms of risk behaviors or pathways during widowhood. Thank you.
Maybe I'll also ask a question. My question is for Kerrigan. I'm wondering whether this kind of OHIP analysis has been done in older women, particularly in WISE, and how those results would compare to STAR.
Yes, actually, so that was the basis of my dissertation. And we looked at that within WISE. We did a one-time cross-sectional survey. Way back in early WISE in 1994, 1995, they did exams and more thorough oral health assessments, and then that kind of all went away. So I brought one back in 2018, and we found, as we would expect, that older women do have worsened oral health-related quality of life. As we get older, we tend to develop more dental issues. If I see in a 50-year-old woman, recession or missing teeth, I'm not as alarmed as, say, a 30-year-old. So we are seeing it higher in older women. And one of the beauties of this CROWN study is we're purposely enrolling young women under age of 40 and older women over age of 50. We're implementing the OHIP 14 along with a bunch of other dental measures. We're also collecting periodontal measures, dental caries assessments, so we can not only look at oral health-related quality of life, self-reported oral health, but actual clinical indicators to look at differences. Yeah, thank you.
I also have a question for Kerrigan, and it's more related to clinical care. We have a multidisciplinary approach, to HIV care, and we generally have psychologists, a pharmacist. Should we be advocating for having dental expert in our clinics?
Well, and so a lot of my work, aside from this with Dr. Lisa Metch, is looking at the role of dentists and oral health in overall health. And we're trying to, we're getting there, but a lot of dentists, particularly older dentists, have this drill and fill model. I look at the teeth has a problem, I fill the tooth. But what we're really advocating for is that dentists, we should be not treating overall health, that's outside the scope of practice. But for example, something like rapid HIV testing, we can have hygienists do it. You go in for your cleaning, would you like a rapid HIV test? We do a quick swab by the end of your visit. We can tell you the results, and if it is positive, we can send you for confirmatory testing. Heart disease, blood pressure, by a show of hands, how many of you have your blood pressure taken by your dentist or your hygienist? Okay, so we have a few, but that's a problem, because if I work in special needs dentistry, I can't tell you how many times I've taken a blood pressure and it's through the roof. When was the last time you saw your physician? Years ago. A lot of dental procedures you can't do if a blood pressure is too high. So again, we're not looking at the dentist to treat, we're looking for screening, referring. Domestic violence, interpersonal violence, that's huge. 70% of manifestations from domestic or interpersonal violence, head and neck. All you have to do is look and ask. Again, you're not expected to treat, but by simply asking and then referring, you can make such an impact. And in CROWN, that's one of the things we're asking about. Has your dentist ever talked to you about what medications you're on? Again, we're not expecting a dentist to change your hypertension medications, but especially for medications to treat mental health disorders, it can cause dry mouth. Let's talk about that. How can we combat that? So just getting more involved in the big picture. So,
Great.
ideally, yes. Practically, we have a ways to go. So.
I guess since we have a couple more minutes, I'll ask one more question to Lauren. What's your hypothesis as to why certain comorbidities are associated with previous pregnancy history only in certain age groups?
That's a very good question that I think deserves further exploration, of course. I think interestingly, so I presented data mostly in terms of age and pregnancy history stratification as overall burden, but didn't share with you all, for the sake of time, the individual comorbidities and sort of how those differ across the age spectrum. And so in these data, at least, the comorbidities that appear to differ by age and pregnancy status may be those that you expect in terms of like hypertension and psychiatric illness and even cardiovascular disease. And so I think it could potentially be related to the distribution of comorbidities that may impact certain age groups, and in particular those younger age groups, and therefore those that have had, some degree of pregnancy history, but still need to evaluate further and look over time.
I think we'll bring the session to a close, so let's thank our speakers. And I think we're ready for lunch now, so thank you.
Before we, break for our lunch breakouts, I do want to just quickly acknowledge our planning committee for this HIV and Women Symposium.